Dr. Fecchio was introduced to me by Professor Adenauer, who many here, of course, know, because there were colleagues in a laboratory at the State University in Milan, Università Statale di Milano, which is my hometown in Italy. And Matteo, I think you're not from Milan, but anyway, nearby. That's where we both grew up. And right now, Matteo is an instructor at Massachusetts General Hospital. And after completing his PhD postdoc at Università di Milano in Italy, where he worked under Professor Marcello Massimini, who was also Professor Adenauer's PhD advisor when Adenauer did his PhD in Italy. You've been working, Matteo, with several things, but mostly with transcranial magnetic stimulation combined with electroencephalography. And in fact, the subject that you're going to tell us a bit about today is how to apply techniques dedicated to the joint analysis of EEG and the effect of transcranial magnetic stimulation, specifically for, in the case of today's talk, specifically for ICU patients, so patients admitted to the intensive care unit who are very critically ill, and for which it is instrumental to improve our assessment of their consciousness. So I'm sure that you will tell us a lot more about this. I won't get too much into detail, but I think that everything that is related to the intensive care unit, UTI, for those of us who don't know this terminology for unidade de terapia intensiva in Portuguese, I think that everything related to UTI and ICU has become so common knowledge, unfortunately, in the last 3 years, that now I think there's enough awareness to discuss more about a lot of different topics. As you know, Matteo, I also do my research on, and my students, most of them know, on critical care problems, on ICU problems, but very different from yours. It's just a very complex environment, and I'm just happy that today you will show us something that is quite distant from my things, so I will also learn something new. So that's it. Just let me give a couple of communications for my students. I ask you to, also texted you earlier on, please stay after we finish with the webinar and Dr. Fecchio leaves, so we'll talk about our stuff. And for our guests who registered through CX, I will let you have your certificate of participation, if I can today, if not tomorrow. Okay, so Matteo, I think I gave you, a brief introduction. I hope that I didn't say anything wrong. No, and now the floor is yours, and thank you again for joining us.
Thank you. Can I share my screen?
Yes, and I will tell you if we see everything, if everything is fine.
Do you see my screen?
It's loading. I do. It's presenter mode, so that should be fine. And if we have any issue with, sometimes I know that slides don't run, so I will let you know, but I think it should be fine.
Okay, thank you so much. Thank you so much, Federico. Thank you so much for the kind introduction. So as you mentioned, today I'm going to tell you something about how to use transcranial magnetic stimulation coupled with electroencephalography in the intensive care unit to detect consciousness. So I know that talking about consciousness, especially to a group of bioengineers, may seem weird. It seems weird. I mean, I'm a biomedical engineer too, so at the beginning it was weird to me. Let me give you a little bit of background, my background. So I studied at the University of Pavia. I was born in Pavia, and Pavia, the University of Pavia, is one of the oldest universities in the world. At the end of my studies there, I decided to join the lab of Professor Marcello Massimini at the University of Milan, where I met Professor Casali, Adenauer. He helped me improving how to perform source reconstruction of TMS evoked potentials. And thanks to him also, I graduated. And after that, I decided to stay at the University of Milan under the lead of Professor Marcello Massimini. Here I did my PhD in physiology, and I continue to study transcranial magnetic stimulation, the application of transcranial magnetic stimulation and EEG in healthy controls and patients affected by disorder of consciousness. Here I focused not only in detecting the level, let's say the level of consciousness, detecting the consciousness in these kind of patients, but I mostly focused my career in try to understand which are the mechanisms that underlie the loss of consciousness in these patients. I spent there also part of my postdoc career, and in 2020, the beginning of 2020, I moved to Boston at Massachusetts General Hospital. Before moving to Boston, I also performed other studies which are related always to transcranial magnetic stimulation. We try to understand what lead to the difference that I will show you later between the responses during wakefulness and sleep. When I moved to MGH, after a couple of years, I became an instructor in neurology, so almost 1 year ago, and under the lead of Dr. Brian Edlow. So here I'm part of the neuroimaging of coma and consciousness lab. So here we perform several studies, as you can see. So we perform a study, for example, that is focused on try to understand, to find atlases and connectivity of the ascending arousal network, which is a subcortical neuronal network that is critical for consciousness. We perform also ex vivo connectomics study, which it's a post-mortem imaging and histopathological study of the brain that are from patients who died from severe traumatic brain injury. We also have a study that promotes the early recovery of consciousness, and of course, we have a study to detect the level of consciousness in patients in the ICU. So we apply several paradigms. I will show you later what I mean, and also we use the Tms-Eeg to detect capacity for consciousness. This thing of detecting consciousness is crucial in these patients. I will show you why, but it's crucial because in states like the United States, where it's possible to withdraw the therapies, it's essential to let the family and the clinician know if the patient is conscious or may recover. So today, I'm going to show you why and how we detect consciousness. It's possible to detect consciousness in a clinical environment. I will tell you something about the Tms-Eeg and the potentials that we record, how to quantify these potentials, and the limitation that we are facing to move this technique to the intensive care units. Let's talk about consciousness a little bit. The only way, if you think that we have to assess consciousness in another individual, is an input-output paradigm. So we know that we are conscious. I know that I'm conscious now, but I don't know, for example, if the person in front of me is conscious or not. So what I have to do is to ask something. I can ask to perform a task, or I can ask some questions, and if the person in front of me gives me an answer that I think it's appropriate, I think that that person is conscious. But in case executive and motor outputs or even sensory inputs are there are deficits of executive motor outputs and inputs, we don't know. We cannot tell if that person is conscious or not. So, and this is what we faced every day in the intensive care unit. In the clinical setting, consciousness is defined as the presence of arousal in a normal, let's say in an healthy control, and the presence of awareness. But when someone had an injury, a traumatic injury, brain injury, and ended up in a coma, usually these patients, they do not present arousal and do not present awareness. So this is defined as coma. Not having arousal means that the patient is with the eyes closed and is not able, doesn't have a wake-sleep cycle, for example. From here, there are different scenarios. For example, a patient can die, or a patient can open the eyes and regain functions and go back home, or the patient can open the eyes and ended up in a vegetative state, or as it is called now, unresponsive wakefulness syndrome state. So these patients, they have the eyes open, but the level of awareness is still low, meaning that the patient is there with the eyes open, but is not aware of the environment, cannot experience anything. There are other patients which are called minimally conscious state patients, where again, they have the eyes open, but in this case, the level of awareness may fluctuate. And there is a huge error in discriminating these two categories of patients, vegetative state and minimally conscious states. To detect consciousness in a clinical setting, in a clinical environment, it is usually used the coma recovery scale revised. So this scale is used to detect behavioral responses in these kind of patients with severe brain injury. However, as I said before, deficits in sensory, executive, and motor functions may limit the patient's behavioral responses and thus confound the assessment. For this reason, the American and European Academy of Neurology are now endorsing the use of MRI and EEG to detect covert consciousness or cognitive motor dissociation in these patients. So covert consciousness is defined as the ability of a patient to volitionally modulate the brain activity. So basically, what we do is to put earphones in a patient's ear and play a recording where we ask the patient to keep opening and closing the right or left hand, and then we wait 10 seconds. And then we can record our EEG, and then we cut epochs of time. So we have electrodes and time. We perform a power spectral density analysis, and then we feed a support vector machine with this data. And this support vector machine tells us if the patient were able to modulate the brain activity. If so, we assume that the patient is covert consciousness. But these tasks are very cognitive demanding. Just try. Imagine for 10 seconds to squeeze your hand. It's not so easy. So the false negative rates of these tasks are pretty high. So if usually it's around the 25%. Recently, the Tms-Eeg has been proposed, and the perturbational complexity index have been proposed to assess consciousness in this kind of patients, because we showed unprecedented sensitivity and specificity for detect capacity for consciousness, meaning the presence of any kind of experience, okay, which is dreaming or hallucination in patients and healthy control. Tms-Eeg is one of the plus of the Tms-Eeg is that does not require the patients to be involved in a task. So I would like to show you this video. This video is a recording from a patient. As you can see, just to give you an idea, an example, this patient has the eyes open. Yes, his father is talking with him, but the patient is in a vegetative state. These patients, even if they are not aware, they recover. As you see, they have the eyes open. So basically, they recover the sleep-wake cycles. They can open their eyes, but they do not show any behavioral signs of consciousness. Despite this, these patients have large parts of the thalamocortical system that is preserved, is structurally intact and spontaneously active. We know that because with the TMS, we can stimulate this cortex, these preserved parts of the brain, and we can record the response of this perturbation with the electroencephalography. These techniques so allows to directly and non-invasively stimulate the brain, bypassing all the sensory pathways. So basically, as I told you before, there is no need, even if the patients they have motor impairments or sensory impairments. Here we are directly stimulating the brain, and as I told you, does not require the subject collaboration. This is the experimental setup for a Tms-Eeg experiment. So we have a TMS and a structural neuronavigation. The subject is fitted with an EEG cap. Usually we are using a high-density EEG, meaning we have like 60 EEG channels, EEG amplifier to record the EEG activity, and a computer for a functional neuronavigation. I will show you later what it is. Now, let me introduce you a little bit of each piece of this equipment. This is the first, basically, TMS, first experimental TMS. Barker used it in 1985. And as you can see, he was stimulating the motor right cortex here with this coil. And he was recording the EMG, the electromyographic activity of the left arm of this subject. So the idea here was that if the TMS was successful in stimulating the motor cortex, so the cortical spinal tract, we should have seen a muscle contraction. And this is what happened. The point is that, and this is what happened. So there are different parameters that we can use to characterize the different protocols. One of the most common parameters to define a protocol is the interpulse interval. So we can basically distinguish two classes. One is the conventional RTMS and another one is the patterned RTMS. And we can distinguish them based on the duration of the pulse interval, or if the pulses are delivered in a burst of pulses, or in a continuous way. We focus on the use of what is called a single pulse protocol, or a low frequency repetitive TMS. Here we deliver pulses that are around every 2 seconds with jitter in order to avoid the patient's habituation. The TMS exploits the electromagnetic induction law by Faraday, which says that a time-varying current in a coil generates a time-varying magnetic field, which induces a current in a conductor, which in this case are our neurons. Let's talk now a little bit about DG. I don't know if you ever used an EG before. Here, as you can see, we used a net, but with the 62 EG electrodes. And these are placed in what is called a specific montage, a 10-20 montage. So as you can see, the position of each electrode is measured from located in a specific position, which is calculated by measuring the distance from nasion and median. And the EG records the voltage voltage difference between different points using a pair of electrodes that compares one active exploring electron with another one that is called the reference electrode. And this is crucial because if you move the position of the reference electrode, of course, you will record something different. If we try to couple the TMS and EG with a traditional EG, the electric field that is generated by the stimulator usually will saturate the amplifier, even for 5-10 milliseconds. But we are interested in a response that lasts 500 milliseconds, less than 500 milliseconds. So if we use traditional EG, we are basically blind to the TMS pulse. Indeed, we have to wait a little bit for having the first TMS evoked potential with an high density EG. This is a little bit of history. So the first successful recording of a TMS EG was performed by Krakow in 1989. And he was stimulating a motor cortex on one hemisphere, and he was recording the EG response from the contralateral hemisphere. So again, we don't have an idea of what is happening in the area that we are actually stimulating. We have to wait almost other 10 years to have a first TMS EG with high density recording. Ilmoniemi and Virtanen here proposed this circuit, the use of this circuit in an EG. Basically, this is called a sample and hold circuit. They were basically shutting down the EG, the recording of the EG, a few microseconds before the delivery of a pulse. And they were reconnecting the EG 2 milliseconds after the TMS pulse. This basically gave us the chance to collect a TMS evoked potential, a real TMS evoked potential. And this is the first study performed by Ilmoniemi. He was stimulating two primary cortexes, the motor cortex and the occipital cortex. And he showed that he was able to reveal cortical reactivity and connectivity after a TMS pulse stimulation. The idea of using this gating approach was successful, but this EG is not commercialized anymore. So if we want to use TMS-EG, we have to think about other approaches. And the most common approach is to increase the dynamic range of the amplifiers, of the EG amplifiers, and the sampling rate, keeping the bandwidth of the filters as larger as possible. This is because when we deliver one pulse, as I told you before, if we use a traditional amplifier, we saturate the EG because the combination of these two techniques generates this kind of artifacts. This is called ringing or step artifacts, which is tens of milliseconds, thousands of milliseconds, millivolt, while our response is in the range of 10 microvolt. So this guy here is thousands times bigger than our response. As you can see, if we have this artifact, all the channels, these are the EG channels, as you can see, they are flat. They seem to be flat. Another thing that we have to keep in mind when we want to couple a TMS and an EG is the compatibility of not only of the EG, but also of the electrodes. So here, in this old net, we were using a pin-shaped electrode, while in the newer one, we used a C-shaped electrode. This is crucial because if this ring here is closed, when we deliver a pulse, the current may flow in this ring here. The electrodes can be overheated and they can burn the skin of the participant. Just as a reminder, here, I will show you.
This is an empty can. If I put it on the coil, and if I deliver the stimulus, it jumps.
Okay, so this is a reminder just to say that, okay, when we deliver a pulse, a TMS pulse, we are generating a very brief but very intense magnetic field. And if the electrodes or everything that we are interacting with is not compatible, may cause an issue. Imagine to deliver a pulse like this when we perform, for example, an intracranial recording with intracranial electrodes. If they move when they are in the brain, well, they may be uncomfortable for the patient. Then another piece of the equipment is the structural neuronavigation. So usually what we do is to perform the MRI of the patient or the healthy control prior to the experiment, prior to the recording. We load this MRI in the neuronavigation and we co-register the head of the patient or the healthy controls with the MRI. In this way, when we move the coil over the head of the patient, we know exactly where we are stimulating. And if we are out of the target, even for a few millimeters, this specific stimulator stops firing, stops delivering pulses. And this may seem trivial, but consider also that the coil is heavy. So during a recording, it's possible that we move the coil. So if we want to stimulate, if we want to be sure to stimulate the same point over time, we need to have a neuronavigation. Moreover, we need to know exactly where we are stimulating and which is the direction of the electric field when we hit the cortex. This is because it has been proven that the stimulation is maximally effective on the gyral crowns that lay orthogonally to the induced electric field. Another reason is that with the neuronavigation, we can record the position of each electrode, which is crucial if we want to perform a longitudinal assessment, meaning that if we want to perform the same stimulation across days or across time, we need to put the EG cap in the same position. So we need to know where the electrodes are, or even if we want to perform a source modeling, we need to know where the EG electrodes are placed. all these things are crucial, especially when we use the EEG, because as I told you before, so if we do not want to move the coil from where we are stimulation, the response, the reason is simple. It's because if we move the coil, we stimulate a different cortex and we obtain a different response. So we want to keep the coil in the same position. Moreover, in patients, if we stimulate an area that has a lesion, we stimulate if we put the coil over a lesion, the TMS is not effective. And as you can see here, we record basically a flat line, while when we target a preserved cortex, we obtain something like this, a response. Finally, we need a functional neuronavigation. You remember I told you that Barker in 1985, he was looking for a contraction of the muscle hand. And this is doable when we target the motor cortex. But if we want to target areas that are outside of the motor cortex, we need to have another kind of readout. And our readout is DG. What we are collecting is Tms-Eeg. So our readout is DG. And we need to be able, in real time, during the recording, to assess if we are effectively targeting the brain or not. So to summarize, we want to perform a Tms-Eeg assessment. We need to have basically 4 pieces of equipment: the TMS, an EEG, a compatible EEG with the TMS, a structural neuronavigation, and a functional neuronavigation. Let me show you here a little bit of data, so how we visualize the data and how we obtain a TAP. This is a raw recording. Here we have the channels, 62 channels in this case. Each line is what a channel is recording. Those are, here we have time, so we have around 10 seconds of data. Each blue line that you see here is a step artifact. What we want to do, you see that this EEG signal seems to be pretty noisy, so we have muscular activity, we have eye movement. And what we want to do is to clean, to remove everything that we may consider as noise. So first of all, we want to apply some filters. To doing that, we have to remove the step artifact and then apply the filters. But let's focus now on how we generate a TMS input potential. So if we zoom, this is a window where if we zoom around a specific time window around the TMS pulse, this is how it looks like. As you can see here, basically you cannot, here in the middle we have the TMS, and as you can see, you cannot distinguish the TMS input potential from what is called the post-stimulus and the baseline. We need to perform several pulses in order to see a TMS input potential. So those are epochs, those are channels. Each one of these is a channel, so we have 62 channels superimposed. And we may record even 250 pulses. And when we average them, basically we reduce what is not in phase, which is what we have in the baseline, and we highlight what is generated by the TMS. So we can clearly distinguish a baseline and a post-stimulus. This is another way to visualize the TMS input potential. So here we have the 62 channels in a topographical distribution. And if we focus on a specific time point, we can plot the voltage topographies. We can plot voltage topographies. And here, for example, we can see that the maximum of the response is located here. So as I told you, we have, when we put together two techniques, every kind of techniques, TMS and MRI, TMS and EEG, TMS and MG, every time there are some kind of, we create some kind of artifacts. The two, usually two techniques may interfere to each other. I already showed you the ringing artifact. There are other artifacts. For example, this is the recharge artifact, which is due it is due to the fact that basically the TMS, we have a capacitor that is charged. When we deliver the pulse, we discharge the capacitor, and then we want to recharge it. If we recharge the capacitor, when we recharge the capacitor, this recharge may affect the EEG. And this put some kind of, you see these spikes here. The only way we have to avoid this kind of artifact is to move it in time, so out of our window of interest. Another kind of artifacts is the decay artifact. This is due to a poor, usually a poor connection between the skin and the electrode. So what we do is to scrub again the skin of the participant and reperform the impedances that basically create the connection between the skin and the electrode. Finally, we can have also some biological confounds. For example, this is a muscular artifact. So when we stimulate the brain, in between, we have to remember that we have cranial muscles. So when we stimulate the brain, we may activate this muscle, especially if we stimulate areas that are far from the midline, that are very lateral. We can recognize this kind of artifact because it's biphasic. You see, it goes down and up or up and down. And it's huge, it's really big. And it's mainly located on lateral areas. Another common confound is the auditory potentials. So every time that we deliver a pulse, a TMS produces a loud click, something like this. And when our brain perceives a click, it responds with these waves, a positive, negative wave. It's N100, P200. This has a really specific topography and latency. In order to avoid this, what we usually do is to put earphones in the ear of the patient or the subject and to play a masking noise. So until now, we saw how these techniques may interfere, but how can we recognize a TMS evoked potential? So the TMS evoked potentials, the first component is usually bigger in the area under the stimulation site. And I know this may seem trivial, but it's not. For example, if you imagine the auditory evoked potential, they are mainly located at the vertex. So, but with the TMS, we are actually stimulating one specific part of the brain. So we expect that part of the brain responds before everything else. Then TMS evoked potentials are lateralized, meaning that if we zoom over a line of channel, this one, they are clearly different from left to right. When we have this condition, we know that we are effectively targeting the brain, and our response is genuine and is coming from the brain. So to summarize here, so we have, as I told you, we are putting together two techniques, and that may interfere to each other. We can have artifacts that are related to the fact that we are we are that the TMS is putting in the EEG that is like the step artifact and the decay artifacts. We have also other biological confounds, but we can get rid of them. And once it's done, we can use the EEG as a readout and to understand if we are effective when we target the brain. Let me show you briefly which are the characteristics, the features of the TMS potentials. So this is a study performed by Rosanova et al. And colleagues in Milan in 2009. So they were stimulating 3 different parts of the brain, and they observed that when they were different, when we target different cortexes, we obtain different responses. So the TMS is specific for stimulation site. If we measure the latency between these peaks, we see that these responses oscillate in a specific frequency bench. So we have a gradient from a posterior anterior gradient. So the responses that we obtain when we stimulate the occipital cortex, they oscillate in the alpha. The parietal, they oscillate in the beta, while when we stimulate the premotor, these responses oscillate in the high beta or low gamma band. As I told you before, the TMS potentials are repeatable over time, meaning that if we perform the same stimulation over time with the same parameters means the coil placed in the same position, the EEG electrodes placed in the same position, same intensity, same orientation of the coil, the subject in the same state, we obtain responses that are very similar. You see that here we have 2 responses that are almost perfectly overlapped. While if we change these parameters, the responses are different. As I showed you before, if we change for example, the stimulation site, we obtain different responses. So now we want to apply this technique to different experimental models of loss of consciousness, which is sleep and anesthesia. When we stimulate the brain during wakefulness, so as I showed you before, we obtain responses that we defined as complex. This complex response, meaning that we obtain the responses as several peaks, but if we take a look where these responses are generated, they are generated from a different part of the brain, meaning that we are activating one part of the cortex, and this activation is causally traveling across the brain. And this activation may last also for 300 milliseconds, 400 milliseconds. If we perform the same stimulation during sleep, we obtain a completely different response. You see, this is a response that we called as a sleep-like response. It's a positive negative wave. If we reconstruct the sources, we notice that this activation is not traveling anymore in other cortexes. So there is a loss of effective connectivity. And this response is also short in time, shorter than a response in wakefulness, for example. So this is our find. This was the finding that Marcello Massimini found in 2005, published in 2005. So we have a response that during wakefulness is complex. During non-REM sleep, meaning deep sleep, is simple, stereotypical, because all channels all the channels do the same thing. But if we perform the same stimulation during REM is rapid eye movement. So basically, usually when we dream, the response is became complex. So dream is one model of disconnected consciousness. Is something that we all experienced in our life. So we know we are in our bed, so we dream, the most vivid dream, but we are completely disconnected from the environment. But nonetheless, we are conscious. We know that something is happening. We are experiencing something. And the participants, they gave us the report. Basically, we were waking up the participants. They were waking up the participants just right after the assessment, and they were saying if they were experiencing something or not. Then we moved this. We performed this technique also in during anesthesia in healthy controls. So we started again from wakefulness, and then we delivered, for example, midazolam in doses where the participants were able to were unconscious. They were not able to report any kind of experience. Same thing for propofol, and also here we obtained, as you can see, sleep-like responses. Xenon is a little bit different from propofol and midazolam. With xenon, we have a response that is more global instead of the local responses with propofol and midazolam, but still, it's a simple response, positive, negative response. When we perform ketamine, we obtain this kind of response. It's a complex response. You see several peaks. But when we asked the participants if they were experiencing something, they told us that they were having hallucinations. So again, experience, again, consciousness. We finally applied the TMS to disorder of consciousness patients. And Rosanova and colleagues showed that when they were performing TMS in a vegetative state patient, they obtained again a response that looks like to the slow wave responses, a positive, negative wave. While they were stimulating a locked-in syndrome patient, are patients with a specific lesion in a subcortical structure. So they are completely paralyzed, but they are completely conscious. So they can only move the eyes, and sometimes where it's a complete locked in, they cannot not even move the eyes. But again, here the TMS potentials are complex, and are complex also when we were stimulating the minimally conscious state patients. So, like any other biomarker process, to develop a Tms-Eeg biomarker, we need to perform a multi-step and iterative process from discovery to development to validation, and finally to arrive to the clinical use. So right now we are at the discovery. Let's try, which is every time that consciousness is absent, we have a response that is local or global, but stereotypical and simple. So positive, negative wave. While the patients or controls are conscious, we have a global and complex response. So the next step is to development to try to quantify this complexity in these responses. So as I told you, when we stimulate, for example, a healthy control during wakefulness, we have that we activate one cortex, and then this activation travels to other cortexes. So actually, Professor Casali was to create this perturbational complexity index, which is generated in this way. So he had the idea of calculate the source modeling of these responses for each instant of time, and to compare the post-stimulus with the pre-stimulus. So he was basically put into zero everything that was not statistically generated by the TMS input potential. So he had a matrix like this one, and what he did was simply to compress this matrix with the Lempel-Ziv approach, the one we use to compress the imaging, and to normalize this for the entropy. The idea is that if we have a local response, PCI is going to be low. Same way, if we have a global response, but simple positive-negative wave, PCI should be low. But if the response is complex, PCI should be high, because basically it's the vocabulary needed to, the words needed to compress this response are higher than in the previous cases. So we have a discovery, we have the development, we have to validate our measure. The problem in the field of consciousness is that everyone wants to validate their measure in the patient population, so in a population where we do not know if they are conscious or not. So we had the idea of to apply this measure, first of all, to a benchmark population in people that were able to report if they were conscious or not, and then to come out with a threshold and apply that threshold to the patient's population and see what happens. So first of all, we noticed that the two distributions of consciousness and unconsciousness were completely separated. So we found that PCI has an incredible sensitivity and specificity of 100%. So we came out with an empirical cutoff, a threshold, that we applied first of all to the minimally conscious state patients. And we found that we were able, with an unprecedented sensitivity, to detect MCS with a 95% of sensitivity. Then we applied the PCI to the VS population, and we found that with a few patients, we were not able to evoke any kind of response. In other patients, VS patients, we were able to evoke a low complexity response, a sleep-like response. But in another portion of these patients, we found that they had responses that they were complex, where PCI was in the range of the minimally conscious state patients. And this was almost the 20% of these patients, meaning that these patients, they were probably, let's call them cover conscious, they are there. So what we need to do is to try to restore communication with them. So final step, are we ready for the clinical use? Actually, no. So we need to perform other steps right now. So first of all, in the intensive care unit, what is essential is the time. So for the data acquisition, it took 2-3 hours to have a full data set. So we have to put the EEG cap in place. We have to find the optimal parameters for the noise masking. And then we have to find out the optimal spot, or to target the brain without having, for example, decay, muscular artifacts. And then we need time, 10 minutes to record one session. And what we usually do is to perform a cortical mapping, because, as I showed you before, if we target a lesion, we have a flat response. But maybe that spot was the wrong entry point for the TMS. So what we usually do is to stimulate as much cortex as possible. So the ideally was to try to find some a priori that are going to lead us to the spot that may generate the highest PCI value. Another thing is the data analysis. Analyze this data takes time. We don't have right now an automatic approach. So when we are in the ICU, we have to provide results to the families and clinicians in 24 hours. And sometimes to give these results is not possible in such a short amount of time. Another issue is the EEG cap. So as I told you, we used 62 EEG channels with a cap. It's not possible to use an EEG cap in an ICU. Usually in the ICU, you have a technician that comes there and put the EEG leads. And they are usually 19. Are these leads compatible with the TMS? We still do not know. So we have to try. Moreover, 19 channels are enough to perform a source modeling and so calculate PCI. So these 19 channels may affect part of the analysis, the preprocessing and the PCI calculation. To shorten the acquisition, we can reduce the interpulse interval. As I told you beginning, we are now we are stimulating at an interval of 2.3 seconds. So the idea can be to shorten the interval, so perform one stimulation every second, 2.3. But if we do that, do we have the same responses? Are we generating plasticity? Are we changing the plasticity of the brain? We do not know that. So it's something that we have to test. And our benchmark population will still be the same or will be different. So once we do that, we have to check if our calibration is still working. So we were now in a validation step. We have to go back to the development step and finally to move again to the validation. Our discovery doesn't change because what we think is that it's solid. It's something that, again, as I told you, with an unprecedented sensitivity and specificity, but still needs some refining. So conclusion. So I showed you that the early detection of consciousness is crucial in the ICU, and I explain you why. Because these patients, again, as especially in states like the United States, family can withdraw the therapies and let the patient die, basically. I explain you the different modalities to assess consciousness in the ICU, and I showed you why TMS is so important, because it probed the thalamocortical circuit non-invasively and directly. I showed you that TMS evoked potentials are repeatable over time and are sensitive to TMS parameters. And when we stimulate the brain in an unconscious subject, we obtain simple, stereotypical, local, or global TMS evoked responses. While when we stimulate during consciousness, when the subject is conscious, we obtain complex responses. And finally, how to quantify this complexity with PCI. And even if this, we know that even if these are really promising, we know that we need to take a lot of steps to move before moving these techniques to the ICU. I would like to thank my colleagues here at MGH and Università degli Studi di Milano, Federico, for having me here today, and Professor Casali and Karina that is here. Thank you. Any question?
Thank you very much, Matteo. It was really very, very interesting, and